Good afternoon, everyone, or good morning based on your time zone. Thank you for joining us today for the Long-Term Care Hospital Quality Reporting Program Provider Training. My name is Mark Stewart with Econometrica, and I will be your host and moderator today. This LTCH QRP training is intended as a supplemental refresher. It does not replace previous trainings held in November 2015 or August 2016. All of the materials, including videos from those previous trainings, are available on the CMS LTCH QRP website. The next few slides highlight a reference list of acronyms that will be used throughout today's presentation. I won't read these to you, and presenters will do their best to state the full name or condition instead of using acronyms. However, many, including, for example, CAUTI, shown here, are commonly used, but you will have these slides available as a reference should you need to refer to it. Today's webinar is being recorded, and I have just a few housekeeping items for you. This training, like the others that I previously mentioned, will be posted later to the CMS LTCH Quality Reporting Program website. We will provide you with details on accessing the recording via email when it is available. As you've probably noticed, there is closed captioning available at the bottom of the screen near the middle. The phone lines will be on mute today for the duration of the presentations, and due to the large number of attendees on today's webinar, we are unable to field questions over the phone. But you are able to submit questions electronically if you follow the questions we'll discuss soon in the presentation. If you have questions throughout any point on today's presentations, please enter it on the form that will walk you through. This will assist with collating all the questions. If you're not comfortable using the link, or for some reason it may not work for you, you may also ask questions at the bottom left-hand corner, which is labeled Q&A. We will be monitoring all of the questions submitted during the presentation, and we'll have time for some at the end of today's session. Responses to all of the submitted questions will be published on the LTCH QRP webpage, and an email will be sent to you when the Q&A document is available. Instructions for submitting the questions electronically are on the next few slides that we'll review momentarily. This slide illustrates how to download today's presentation slide deck. You'll click on the Media Library icon located on the top right of your screen to access the shared files, and then click the green arrow next to the file name in order to download the presentation. The presentation slide deck, like other materials, is posted to the LTCH QRP website. If you would like to display the slides in a larger view on your screen, click the title of the PowerPoint presentation, and the option for full screen will appear. If you click on full screen, you will change your view only to be in full screen mode. To exit the full screen, simply hit the Escape key on your keyboard in order to return to a normal view. During a portion of today's webinar, one of our speakers will be conducting a live demonstration of the reporting system. At that time, when the presenter shares her desktop in the screen share mode, click on the Fit to Screen view to see the entire screen that is being shared. Throughout today's event, we'll be using polling questions. These questions allow the speakers to ask questions that gauge your understanding of the material being presented. Each question will appear at the bottom of your screen. Review the answer choices offered and choose your answer. Use your mouse to click on the circle to the left of your response. There is no need to hit submit. Once you choose your answer, it will be automatically submitted for you. You can change your answer at any time before it is closed. Your answers are confidential and will only be reported in aggregate percentages. Here is an example of the electronic question submission form that was mentioned and the process to use to submit questions during the webinar. To submit questions, visit the web page listed here on the slide. We're sharing the link in the chat box as well, located near the bottom left of your screen. We'll repost the question submission link in the chat box throughout today's proceedings. By clicking on the link shown here, a separate internet browser window will open. Once you get to the landing page, please be sure to enter your name, organization, and email address. After you've entered your contact information, if applicable, use the drop-down menu to select the section of today's presentation that your question refers to. Type your question in the field and then click Submit and send your question to the presenters. After you've submitted your question, you will be able to submit additional questions. If you click here on my screen, it's shown in purple on a small font, but when you're in the application, it'll read in a larger font, Submit another response. Today's webinar was created specifically to enhance provider understanding of the LTCH Quality Reporting Program. We will include a live demonstration to show you how to navigate the LTCH QRP website and identify resources that can assist you. We will conclude the event with a question and answer session and finally a wrap-up. We have a few speakers today. The first I'd like to introduce is Jennifer Farley. She has experience across the healthcare spectrum, including hospital and outpatient, private practice, and nonprofit settings. And her current role is Vice President of Quality and Patient Safety Officer at the Hospital for Special Care. She works to ensure that all CMS, DPH, and Joint Commission mandated quality measures are met through standardized data collection and reporting methods. Recognizing the close tie between quality and education, Jennifer has pursued coursework in instructional design and has extensive experience in building and implementing learning management systems. We're also prepared to hear from Ms. Vicki Golab, who unfortunately has fallen a little ill, but she's going to do her best. Vicki has over 25 years in the post-acute care environment, and she's held various leadership positions as a clinical educator, Director of Risk Management and Compliance, and Vice President Quality. She's currently Vice President of Nursing, CNO, and Acting Director, Case Management, also at the Hospital for Special Care, which is a 228-bed long-term acute care hospital. She's been certified in both quality and rehabilitation nursing for over 15 years and is currently a member of the American Organization for Nurse Executives, National Association for Healthcare Quality, and Sigma Theta Tau International, the Honor Society for Nursing. The third presenter today that I'd like to introduce is Dr. Tree Lee. Tree is a research public health analyst and LTCH analyst at RTI International. He obtained his doctoral degree in health services research and policy at the University of Pittsburgh. During his doctoral studies, he conducted research evaluating care for critically ill patients and LTCH quality. TREE is involved in the development and implementation of public reporting of LTCH performance and leads the development of ventilator liberation quality measures. We are so pleased to have such experienced and knowledgeable speakers present on today's webinar, and we thank them all for being here today. It is now my pleasure to turn today's session over to Vicki Golab. Vicki, the floor is yours.
Thank you, Mark. And yeah, I have a little bit of a chest cold, so I'm sounding a little hoarse, so I apologize. But Jen's right here next to me should my voice fail. So first I'd like to go over the objectives for today. Upon completion of this training, the participants should be able to identify the resources available to guide the understanding of the LTCH quality reporting program. You should also be able to demonstrate understanding of section-specific assessment items to correctly interpret and code the LTCH care data set. And then finally, discuss findings from data analysis on data submissions, including the new assessment items that will be effective April 1st, 2016. This content is not intended to be comprehensive, but actually was put together based on questions and answers from the May and October sessions. I'm going to move into a live demonstration. I'm going to actually take you to the CMS website. First, though, I'd like to go through a disclaimer. This presentation was current at the time it was published or uploaded onto the web. Medicare policy changes frequently, so links to the source documents have been provided within the document for your reference. This presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This presentation may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary and is not intended to take the place of either the written law or regulation. We encourage you to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. So we're going to go out to the cms.gov website. There's a wealth of information here for us to better understand our requirements and our reporting needs. So first off, this is the cms.gov. What you can do is just type in LTCH in the search engine. It'll actually take you to a listing, and the first item will actually take you to the landing page for the quality reporting program for LTCH. I would suggest that you actually add this to your favorites so that when you actually go to look for the information, it's a nice quick click, one step to get there. So what I'm going to do is actually walk through each of the items that are listed on the left-hand side of your screen and just give you some information about what's available to you there and kind of show you the different areas of the downloads and links that can be helpful to us. So this is the landing page. It's the first page of the LTCH QRP program information on CMS. The purpose of the page is to provide users just an overview of the program itself, and there's actually links within this page to get to the federal acts and quality reporting help, as well as archived information. If we start to go down the side, the next item is the LTCH quality reporting spotlight announcements. The purpose of this page is to provide users with important announcements and updates regarding the LTCH QRP. The page is chronologic with the most recent updates on the top. It is updated periodically whenever an important update needs to be communicated to us as LTCH providers. Please refer to this page when seeking information about upcoming trainings, approaching data submission deadlines, updates to training materials and measures and reminders, as well as other useful communications. And you can see right at the top, it's actually information about our webinar today. The next item is the LTCH quality reporting measures information. The purpose of this page is to provide information on the measures that are to be reported by us in accordance with the LTCH QRP. On this page, you will find descriptions for each measure, measure specifications, and updates to measures and data sets. This page is updated as measure updates become available. And if you scroll down on this particular page, down to the download section, you can actually see that the final specifications for our upcoming July 2018 quality measures are available. So I'm going to scroll back up. and continue to go down the page. The next item, let me just get back a little bit more, is the LTCH Cure Dataset and LTCH QRP Manual. This page includes the current versions of the LTCH Cure Dataset, as well as the current manual and associated documents. This page is updated whenever an update is made to either of those resources or a new version becomes available. Once the dataset and manual are updated, the older versions are also available for reference. Scrolling down on this page to the downloads, you'll see that the final version, LTCH Dataset 4, is also available to us. I apologize, there we go. The next tab is the LTCH Quality Reporting Technical Information. This page actually provides technical updates and resources related to the LTCH data collection, submission of the quality data, information regarding the CDC's NHSN information, and the LTCH Cure dataset. Links to these resources can be found on the bottom of the page. Users may also find contact information on this page where to direct questions related to technical issues. Again, this page is periodically updated as changes are made to the LTCH data submission process. The next page is the LTCH Quality Reporting page. A little bit too far. The purpose of this page is actually to tell us about upcoming LTCH QRP trainings, as well as special open door forum presentations by CMS. It also gives you the provider training materials and other resources. Training announcements, reminders, and other updates are organized by date and added to this web page as the new materials become available. If you scroll down to the May 14th update, you actually will see a link to the YouTube, which will actually give you the visual webcast of the information that was provided during that session. Also on this page, again, if you go all the way down, you'll see that there's downloads that are available to you. And all the materials that are presented in any of the educational sessions are there in that download session. The next item is the LTCH Quality Reporting. And as you all know, we started publicly reporting in the fall of 2016, and it did include our wound worsening data, CLADI, CLEPSI, as well as all-cause unplanned readmission measures for 30 days post-discharge. The information in regards to the available reports, resources, education materials, and ability to preview our reports and get a status on the evolution of the public reporting is all located on this page. Downloads at the bottom include actually some information in regards to just the LTCH Compare fact sheet that can give you some insight to how that's being utilized, as well as NHSN guidance. The next tab is the LTCH Quality Reporting FAQs. CMS developed a list of frequently asked questions addressing the general questions that come up about the LTCH QRP, including information about the quality measures, data submission deadlines, technical specifications, and how to submit to the LTCH data set and other useful resources. Again, these documents are uploaded and replaced periodically, and scrolling down this page, you can actually see how you can get to the actual printout of the FAQs. The next page or tab is the LTCH Patient Experience of Care. This tab provides us information on the Patient Experience Care Survey that is being developed for our future use. The survey was recently piloted and is available to us on this tab. Actually, using this, you can get some insight on the possible data collection elements that can be used in the future. Going down the page, the next one is the LTCH Quality Reporting Data Submission Deadlines. And the purpose of this page is to provide data collection timelines and submission dates for the quality measures required from the LTCH QRP. Information in regards to data collection, final submission deadlines for payment are available to you on this page. The next tab, if you should receive a letter of noncompliance, actually will guide you and give you all the information that you would need in order to respond to this. It does provide you also an overview of the data submission requirements with due dates that can be helpful if that is some of the reasons you were given the noncompliance letter. The next two tabs is the LTCH Quality Reporting Help, and actually Jen is going to go through this a little bit more in detail further on in the presentation. And then the last tab is the LTCH Quality Reporting Archives, and this actually has all the old information or previous manuals, spotlights, anything that CMS has provided to us in order to update us on the CMS QRP. And that will be going back to the actual presentation. And we'll advance one more slide. Sorry about that. So the another resource to you is actually the Federal Register itself. And you'll see on this page the actual links for you to actually navigate there. The proposed rules and final rules are published in the Federal Register and typically are released in April and August. The other link on this web page is to the proposed and final rules, and they are posted on that particular site. The other thing that you can actually do is sign up to receive emails directly to your email address in regards to notices and announcements. So if you link and use the top link for the top bullet, you can actually put your information in there and CMS will push out an email directly to you. The same for any notices from CMS about any open to forums. If you go to this particular link, give them the information that's necessary, you again will get emails directly to your own personal email or hospital email to update you on these items. So from here, I'm going to turn it over to Jen. She's going to go a little bit more further into the help desks and how you can actually use them to get the information you need to stay compliant.
Thank you, Vicki, and I'm glad that your voice held out for that webinar. This is Jen, and as Vicki mentioned, I'm going to review the LTCH help desks where we can go for answers on specific LTCH QRP questions that we may have. This is a visual depiction of the help desks, their specific services, and email addresses. We'll go through each of these resources a bit further throughout this presentation. What I really appreciate when looking at this slide is that there are resources available with expertise in any area that I may be searching for guidance relative to how I need to understand the LTCH QRP requirements, and there's a help desk that I can direct my questions to for the best response. For reference, the visual aid provides the specific concern that an LTCH may experience and then the subsequent contact detail. Our first resource is the Quality Reporting Program Help Desk. Here you can gain additional insight into the LTCH QRP requirements, including the data collection and data submission timelines, as well as the LTCH Care dataset items. You can seek information regarding the calculation of the quality measures. An LTCH provider can also find training materials and seek generalized QRP information. This help desk can also assist in triaging any questions if you're unsure where to direct your questions. For example, if I had forgotten how to retrieve today's training material after the webinar is completed, I could reach out to this help desk for guidance on where to locate it. The next help desk resource is the CDC NHSN help desk. LTCHs can reach out to this help desk for guidance on the CDC quality measures such as CAUTI, CLABSI, MRSA, CDI, influenza vaccination coverage for healthcare personnel, and VAE. You can also reach out for any NHSN reporting, enrollment, and analysis questions. As an LTCH provider, if I needed clarity on any topics covered in Chapter 5 of the LTCH Quality Reporting Manual, I could reference this help desk for assistance. The LTCH QRP Reconsideration Process Help Desk is a resource when an LTCH needs clarity on filing a request regarding the receipt of a noncompliance letter from CMS, or needing the deadline for filing a request for reconsideration. It also provides guidance on how an LTCH can dispute a noncompliance finding. LTACs can seek information on the LTAC QRP payment reduction for failing to report the required quality data. If an LTAC is in need of assistance with accessing keys, the associated reporting in the Casper and Laser systems, you can contact the Data Submission and Data Validation Help Desk. Guidance on usernames, passwords, data submission, validation reports can all be sought through this help desk. The LTAC Public Reporting Help Desk is available for LTACs to contact if they have an issue with the reporting periods for the Casper Review and Correct reports, as well as the interpretation of the results for the Casper Quality Measure reports. LTACs can seek guidance on the measures in the Provider Preview reports, the LTAC Compare website, and the LTAC data on data.medicare.gov. It is really important that LTACs are comfortable referencing these various reports, as this becomes our public data related to our quality in our facilities. If you've not gone onto the LTAC Compare website yet and are having difficulty navigating or interpreting the public data, this help desk is an important one. The LTAC Payment Policy Help Desk provides assistance with LTAC payment inquiries, claims, billing, and eligibility and coverage requirements. And finally, the LTAC Vendor Issues Help Desk is available to answer technical questions related to the LTAC Care Dataset, data submission specifications, and the validation utility tool. We have a polling question now. Please select the answer which best responds to the question. How often do you visit the LTAC QRP webpage on the CMS website? A, very frequently or weekly. B, occasionally, monthly. C, rarely, a few times a year. And D, never. And it looks like most of you have logged your answer as occasionally, monthly. I would encourage you to continue to seek out the resources available in the help desk if you have any questions that you think you could benefit from some guidance. Now we have a knowledge check question. So let's see what we learned about our help desk. Which resource below is the best reference for guidance in coding the LTAC Care Dataset assessment items? A, the LTAC QRP manual, B, the LTAC Care Dataset change table, or C, the Keys User Maintenance Application User's Guide. And I can see that the majority of you indicated the LTAC QRP manual, and that is the correct answer. And a second knowledge check we have is related to the LTAC Care Dataset and an unstageable pressure ulcer. If you have a question regarding an unstageable pressure ulcer, which help desk should you contact? A, the LTAC Payment Policy, B, the CDC NHSN, C, the LTAC Quality Reporting Program, or D, the Data Submission and Data Validation. And again, I can see that the majority of you answered with the correct response, the LTAC Quality Reporting Program site. This concludes the Help Desk Resource Review. I'm now going to transition over to Tree Lee, who's going to talk with us about some common coding themes and reminders.
Great, thank you, Jen. We will now review some coding reminders for the LTAC Care dataset based on questions submitted to the LTAC QRP Help Desk. The first topic we'll be reviewing is the use of dashes. In general, CMS expects dash use to be a rare occurrence with some exceptions. The first instance is the coding of section GG discharge goal items. I'll go over this exception in the next slide. The next instance is coding A1000 race ethnicity. A dash may be used if race and ethnicity is unknown. If that is the case, then dashes must be inserted into each of the 6 available boxes for race and ethnicity, which is A1000A through A1000F. Another instance is specific date items such as O0250B, date influenza vaccine received. I will go over this exception in another slide. Section GG includes self-care and mobility items addressing patients' performance and goals. Goals may be coded using the 6-point rating scale, 01 through 06. Please do not use the activity was not attempted codes 07, 09, or 88 to code discharge goals. If goals are not reported for one or more items, then a dash may be used. However, a discharge goal must be coded for at least one self-care or mobility item. In other words, a dash for the discharge goal items does not affect APU determination as long as one discharge goal, based on the 6-point rating scale, is reported. In this slide, there is a link to the LTCH data submission specifications and associated errata files for your reference on dash use for each LTCH care dataset item. There are also situations in which the correct response is to skip an item and leave it blank. For example, item 00250B, data influenza vaccine received, can be blank if the patient did not receive the influenza vaccine in the LTCH. For example, the patient has a known allergy to egg protein and did not receive the influenza vaccine in the LTCH during this year's influenza vaccination season. In this case, item 00250A, did the patient receive the influenza vaccine in this facility for this year's influenza vaccination season, would be coded as 0, no. Subsequently, 00250B can be left blank. Another item is 00250C. If influenza vaccine not received, state reason. This item would be left blank if the patient received the influenza vaccine in the LTCH. Next, let's review the important timeframes for the LTCH care dataset. The standard assessment period for the LTCH care dataset begins 2 calendar days prior to the assessment reference date, or the ARD, and ends on the ARD, for a total assessment period of 3 days, unless otherwise stated. For example, the ARD is on a Wednesday, and the admission date is 2 calendar days prior, which is a Monday. So the total assessment period is Monday through Wednesday, which is 3 calendar days. As we just reviewed, the ARD is the endpoint of the assessment period for the LTCH care dataset assessment record. For an admission assessment, the ARD is at most the 3rd calendar day of the patient's stay. For a planned or unplanned discharge assessment, the ARD is equal to the date of discharge. For an expired assessment, the ARD is equal to the date of death. The admission assessment period refers to the day of admission and the 2 days following the day of admission, ending at 11:59 p.m. For example, a patient was admitted on a Monday at any time, then the end of the admission assessment period would be Wednesday at 11:59 p.m. The discharge assessment period refers to the day of discharge and the 2 calendar days prior to the day of discharge. For example, a patient was discharged on a Friday, then the beginning of the discharge assessment period is on a Wednesday. Next, let's review program interruptions. Program interruptions refer to an interruption in a patient's care given by an LTCH because of the transfer of that patient to another hospital or facility per an agreement for medical services. These program interruptions must not exceed 3 calendar days, whereby day 1 begins on the day the patient leaves the LTAC, regardless of hour of transfer. For example, if a patient is transferred on a Monday and the patient returns to the LTAC on a Wednesday, then that would be considered a program interruption. For such an interruption, LTACs should not complete or submit an LTAC care dataset planned or unplanned discharge assessment. Examples of transfers that do not exceed 3 calendar days include an acute care hospital transfer with a return to the LTAC on the same day, host hospital unit for services such as X-ray, CT scan, MRI, or surgical procedure, and outside appointments such as surgical procedure, dialysis, or diagnostic procedure. So we have our third knowledge check here. If at least one self-care or mobility item, a goal, is entered on the LTAC care dataset, using a dash for the remaining discharge goal items will not affect the APU determination. Is it A, true, or B, false? And all of you chose A, true, which is correct. Now Jen will review section-specific assessment items, section B, J, M, and O.
Thank you, Tree. We're going to review these sections in response to frequently asked questions submitted by LTAC providers. I'd like to begin with a review of section B, but before I do, there are some general coding comments regarding data collection. CMS does not prescribe the specific methodology used by an LTAC provider to capture the data. Each LTAC should determine how best to approach coding, such as using electronic data systems and involving other disciplines to complete portions of the LTAC care data set tool based on facility guidelines and regulatory standards. Section B is our section on hearing, speech, and vision. The intent of Section B is to document the patient's ability to understand and communicate with others. This is accomplished by collecting data in 3 sections: B0100 comatose, BB0700 expression of ideas and wants, and BB0800 understanding verbal content. Section B is intended to document the patient's ability to understand and communicate with others in his or her primary language, whether in speech, writing, sign language, gestures, or a combination of these. However, I do know that our team struggled to differentiate between these sections and subtleties in what data needs to be collected and reported for each. In this section, we'll go into more description of the sections and provide some examples to help us with coding Section B. We'll start with section B0100 comatose. This section documents patient status who are in a coma or a persistent vegetative state, being at risk for higher complication of immobility. Reviewing the medical record to determine whether a neurological diagnosis of coma or persistent vegetative state has been documented by a physician, nurse practitioner, physician assistant, or clinical nurse specialist, as allowable by state licensure laws, is required for this section. It is important to note that other terms such as unresponsive and severe encephalopathy should not be used to infer a diagnosis of comatose. This may be an important clarification to review with your medical staff so that they can be aware of the intent of this section as well. We'll now move along through section BB0700, expression of ideas and wants. For this section, you'll need to consider both verbal and nonverbal expression and exclude language barriers. The patient should be assessed using their preferred language with access to their preferred method for communication, whether in speech, writing, sign language, gesture, or a combination of these, and if appropriate, ensure access to hearing and visual aids and appliances are available to the patient. Many patients in our LTAC setting rely on adaptive devices, such as eye gaze computer screens, for communication, and it is important that the patient's ability to express themselves be assessed with those devices in place. Here we have section BB0700 as it is displayed in the LTAC Care data set. In section BB0800, Understanding Verbal Content, CMS is intending to capture a patient's inability to understand direct person-to-person communication. Such an inability can severely limit the association with other people and inhibit a patient's ability to follow instructions that can affect health and safety. Section BB0800 should be assessed using the patient's preferred language, method for communication, and hearing or visual aids as well. Here is a snapshot of section BB0800 as it appears on the LTAC Care Dataset tool. Now we know that sometimes it can be confusing to distinguish between BB0700 and BB0800. BB0700, Expression of Ideas and Wants, focuses on the patient's ability to communicate and make oneself understood. BB0800, Understanding Verbal Content, focuses on the patient's ability to understand direct person-to-person communication. So let's check our knowledge of section B with a knowledge check question. In this scenario, Mr. B has a history of traumatic brain injury and is currently being treated for sepsis. When conversing with the nurse, Mr. B sometimes has difficulty finding a word. After struggling to identify the word, he will eventually compensate by using other descriptive words. For example, Mr. B recently described coffee as that hot black stuff that I drink in the morning. How would you code BB0700? Code 4 expresses without difficulty. Code 3 expresses with some difficulty. Code 2 frequently exhibits difficulty with expression, and Code 1 for rarely or never expresses self. And I can see that the majority of you answered Code 3, expresses with some difficulty. This is the correct answer. The reason that we would code section BB0700 as Code 3, exhibits some difficulty with expressing needs and ideas, is that Mr. B has some difficulty expressing needs and ideas. Specifically, he experiences word-finding problems. Let's try another scenario. In this scenario, Mrs. K had a stroke several weeks ago and was diagnosed with receptive aphasia. The certified nursing assistant asks Mrs. K if she needs help with her meal. Mrs. K does not. The CNA demonstrates eating by motioning with a fork, but the patient still does not respond. Mrs. K does not have a hearing impairment. The nurse notes that Mrs. K rarely understands what she is saying or demonstrating whenever she communicates with her. How would you code BB0800? Code 4 for A, understands. Code 3 for usually understands. Code 2 sometimes understands, and Code 1 rarely or never understands. Okay, and in this scenario, it appears that 97% of us all coded this as 1, rarely or never understands, and that is correct. And the reason that we code BB0800 as 1, rarely never understands, is because in this scenario, Mrs. K does not appear to understand basic or simple conversations or interactions. That concludes section B. And now we're going to go into some detail on section J, health conditions, specifically falls. The items in Section J are intended to code any falls since admission and any injury caused by a fall. It is comprised of two subsections, J1800, any falls since admission, and J1900, number of falls since admission. The fall definitions are specific. The occurrence must be an unintentional change in position coming to rest on the ground floor or onto the next lower surface, such as a bed, a chair, or a bedside mat. Intentional versus unintentional is an area that our LTAC spends a great deal of time. In order to categorize falls as intended in Section J, you must start by asking first if the change in plane was intentional or not. Many patients in an LTAC have behavioral plans addressing an intentional move to a lower surface. Those instances are not considered a fall. Once you've determined the intention, it becomes easier to delineate an occurrence if an occurrence should be captured in Section J coding. And we'll go through examples that reference this guidance. A fall may be witnessed or reported by a patient or an observer, or identified when a patient is found on the floor or ground. And falls which are reported in this section are not a result of an overwhelming external force, such as a push by another patient. Another important definition is that of an intercepted fall. An intercepted fall occurs when a patient would have fallen if he or she had not caught him or herself, or if he or she had not been intercepted by another person. In an LTAC setting, an intercepted fall is considered a fall and is reported in Section J. CMS understands that challenging a patient's balance and training him or her to recover from a loss of balance is an intentional therapeutic intervention and does not consider anticipated losses of balance that occur during supervised therapeutic interventions as an intercepted fall. Here we can see what Section J1800 appears like on the LTAC Care dataset. It is completed for all discharges, planned, unplanned, and expired. And here we see Section J1900, the number of falls since admission. It is completed for all discharges as well and is coded with one of the following codes. Code 0 for none if the patient had no injurious falls since admission. Coding 1 if the patient had 1 non-injurious fall since admission. Or coding 2 if 2 or more times did the patient have a fall or a non-injurious fall since admission. These are the codes that we'll use for the following 3 questions with J1900. In Section J1900, we need to code the number of falls since admission. This includes all falls since admission, including falls during a program interruption, for which the LTAC becomes aware of. If a patient has a fall while out in an acute facility for a surgical procedure, for example, and during the handoff upon return, the LTAC is not made aware of the fall, then there would be no way to record the fall in this section. However, if the LTAC is made aware of the fall, it would be recorded in Section J. An exception to coding falls on item J1900 is when a patient is discharged to home or to the community. Per the LTCH QRP, if a patient is discharged to home or to the community, then that would be considered a discharge regardless of the number of days away from the LTAC. For example, if a patient is discharged home or to the community, fell, and then returned within 3 days, this is still considered a discharge and not a program interruption. Hence, the fall would not be coded on item J1900, the number of falls since admission. So let's check our knowledge on Section J. In this scenario, Mr. S is ambulating with a walker and with the help of a physical therapist. Mr. S stumbles and the therapist has to bear some of the patient's weight in order to prevent a fall. How would you code J1800 any falls since admission? A, code 0 for no, or B, code 1 for yes. And I can see that the majority of you code 1 for yes. So let's go through the rationale. We would code this scenario as 1 yes because the patient stumbled and the therapist intervened to prevent a fall. In an LTAC, an intercepted fall is considered a fall. Knowledge check number 7. In this scenario, a patient with an acquired brain injury is seated in his wheelchair with the seatbelt buckled. The patient unbuckles the seatbelt and slides himself to the floor without injury. The patient's behavior plan identifies that he exhibits attention-seeking behavior of intentional falls. How would you code J1800, any falls since admission? Code A, 0, no, or B, code 1 for yes? Okay. So in this example, we would code J1800 as 0, no. The reason for this is that the patient intentionally unbuckled his seatbelt and lowered himself to the floor. And if you remember from our definitions, there needs to be the fall needs to be unintentional in order for it to be considered a fall. The patient's behavior plan also clearly documents that this is an attention-seeking behavior. Let's try one more. In knowledge check number 8, a patient is sent out of the LTAC to attend a physician appointment. The patient falls while in the waiting room of the physician office. When the patient returns to the LTAC the same day, the CNA immediately reports this fall to the nurse. There is no evidence of injury related to this fall. The patient had no other falls during the admission. How would you code J1900, number of falls since admission? A, code 0, none, B, code 1, or C, code 2 for 2 or more falls? Okay, and here the majority of us chose coding 1, which is correct. This example, the fall occurred during a program interruption, and a fall that occurred during a program interruption does need to be coded in Section J. That concludes our review of Section J. I'm going to turn it back over to Vicki Goleb, who will discuss Sections M and O.
Thanks, Jen. So Section M is a review of skin conditions. So the intent of Section M is to actually document the presence, appearance, and change in status of pressure ulcers. The CMS manual definition of pressure ulcer is a localized injury to the skin and or underlying tissue, usually over a bony prominence as a result of pressure, or pressure in combination with shear or friction. Of course, we realize that an accurate initial assessment is key to regards to this care data set item. But more importantly, it's also for care of the patient. For us to do an ongoing accurate assessment, it's imperative that each LTAC develop a comprehensive wound education program to ensure that we understand how to correctly stage pressure ulcers so that patient risk factors can be addressed proactively. Current number of unhealed pressure ulcers, M0300. On the admission assessment, M0300A1 through G1 will identify the number of unhealed pressure ulcers at each stage and establishes the patient's baseline assessment. The initial assessment is the assessment that is recorded closest to the time of admission. At HSC, we implemented a 2-nurse skin assessment process that assists us to assure a complete and accurate assessment of the patient upon admission. The discharge assessment, planned or unplanned, items M0300A1 through G1 identifies the number of unhealed pressure ulcers at each stage, and M0300A2 through G2 at the time of discharge identifies if the unhealed pressure ulcers that were recorded on the admission assessment were present on the admission, or if their pressure ulcers were acquired or worsened during the stay. Present on admission, M0300A2 through G2. The present on admission items are coded at discharge and address whether the pressure ulcers were present, 1, on admission when they were admitted and documented as part of that initial assessment, or 2, acquired or worsened during the stay and were not documented as part of that initial assessment. Present on admission M0300 A2 through G2. A pressure ulcer reported at discharge and coded as not present on admission on the discharge assessment would be considered new or worsened. A pressure ulcer reported at discharge and coded as present on admission on the discharge assessment would not be considered new or worsened. This is really why an accurate documented assessment on admission is so important. If the pre-admission assessment at AHSC, we look to see if the patient has had complex wounds prior to coming to us. We actually plan to have our wound APRN available to assist with this assessment on admission. If not, on the usual routine shift when she's available, we actually have trained staff champions on each shift, a limited number that we know are competent to do an accurate assessment, be available to help the nurses assess. So let's walk through a few scenarios. This is present on admission scenario 1. The patient has a stage 2 pressure ulcer and it becomes unstageable due to slough or eschar during their stay. This pressure ulcer was not present on admission. It has worsened. It is considered worsened because the stage 2 pressure ulcer, per definition in the manual, does not include slough or eschar, as these are signs of a deeper involvement of tissue damage. So for this situation, even though the ulcer itself cannot be staged to a higher numerical stage because of the eschar or slough, characteristically and clinically, it is appropriate to assign a worsened status to this ulcer. Therefore, because the pressure ulcer observed at discharge has worsened since admission, at the time of discharge, it would not be considered present on admission. So this represents the coding for this particular case. As we discussed on the admission assessment, the patient was admitted with a 1 stage 2 pressure ulcer. So under M0300 B1, on the admission assessment, it would be a 1. On the discharge assessment, now that the pressure ulcer has slough, it is no longer considered a stage 2 pressure ulcer and would be coded as a 0. M0300 B2 on the discharge assessment would be skipped because it indicates the number of the stage 2 pressure ulcers that were present upon admission. Number of unstageable pressure ulcers due to coverage of wound bed or slough, M0300 F1, on admission assessment was 0 because it was staged as stage 2, but now, due to the slough, they are now considered an unstageable pressure ulcer, and a 1 would be put in the discharge assessment. The number of these unstageable pressure ulcers that were present upon admission on the discharge assessment would be 0. Worsening in pressure ulcer status since admission stage 2 would also be a 0. M0800E, worsening in pressure ulcer status since admission, unstageable, slough, or eschar would now be a 1. So the scenario of coding on this is to kind of reiterate, a stage 2 pressure ulcer per definition does not include the slough or eschar, as these are signs of deepening involvement of tissue damage. And even though the ulcer couldn't be staged to a higher numerical stage, characteristically and clinically, it became unstageable and is now assigned a worsened status. The ulcer would be also reported as worsened in the M0800E unstageable. Let's try another scenario. Present on admission scenario 2. A patient is admitted to the LTCH with a stage 3 pressure ulcer. This ulcer becomes unstageable due to slough or eschar by discharge. We cannot observe the tissues to differentiate between a stage 3 and 4 due to the slough. And we cannot say whether the ulcer actually has worsened based on our definition of worsened. This pressure ulcer would not be considered worsened since admission, since it cannot be clearly staged due to the slough. The unstageable pressure ulcer would be coded and considered present on admission. Let's review the coding for this scenario. On the admission assessment, the patient did have a stage 3 pressure ulcer, and it was coded as a 1 on the admission assessment. On discharge, due to the slough, we no longer can tell that it's a stage 3 pressure ulcer, so on the discharge assessment would be coded as 0. M0300C2, number of these stage 3 pressure ulcers that were present on admission would be skipped. Number of unstageable pressure ulcers due to coverage of a wound bed by slough and or eschar, M0300F1, on the discharge assessment would now be a 1. Number of these unstageable pressure ulcers that were present upon admission would also be a 1. M0800B, worsening in stage pressure ulcer since admission stage 3 would be a 0. And again, due to the presence of the slough, we are unable to restage it to a higher stage and cannot determine that it has worsened. Therefore, M0800E, worsening in pressure ulcer status since admission unstageable, would also be a 0. So just to review, due to the slough, we cannot absorb the tissues to actually differentiate different stages. Because we can't absorb it, we can't numerically stage it. Because this ulcer was not debrided and the assessor was unable to determine if the ulcer remained a stage 3 or had increased to another numerical stage 4, it would be considered present on admission at the time of discharge. Clinicians should assure, though, that an ulcer is as clean as possible and debrided if necessary prior to staging, and should not simply choose to code the ulcer as unstageable. Let's talk a little bit about program interruptions and how it might impact pressure ulcer coding. A patient who is transferred from the LTCH and returns due to a program interruption is not considered a new admission. Therefore, any new pressure ulcer formation, increase in numerical staging that occurs during this program interruption should not be coded as present on admission. If the patient returns to the admitting LTCH in less than 3 calendar days, again, this is not considered a new admission. Let's work through a scenario with a program interruption to see how we would code it. So in this scenario, Mr. F is admitted to the LTCH with a stage 2 pressure ulcer. He's transferred to a short stay acute care hospital, but returns to the LTCH within the 3 calendar days. Upon return, the ulcer is reassessed and staged as a stage 3 pressure ulcer. The patient is discharged 3 weeks later with a healing stage 3 pressure ulcer. So let's walk through the coding of that. On the admission assessment, the patient was initially assessed to have a stage 2 pressure ulcer. So on the admission assessment, it was coded as a 1. Upon discharge, we know that the wound changed when he was out at the acute care hospital and is no longer a stage 2, but is now a stage 3. So on the discharge assessment, the stage 2 pressure ulcer would be a 0. MC300B2, number of these stage 2 pressure ulcers that were present upon admission, you would skip this item on the discharge assessment. M0300C1, number of stage 3 pressure ulcers, on the admission assessment was coded as a 0, as the initial assessment only identified the stage 2 pressure ulcer upon admission. But now on the discharge assessment, although he acquired it during the program interruption, he now has a healing stage 3 pressure ulcer, and on the discharge assessment would be coded as a 1. M300C2, number of these stage 3 pressure ulcers present on admission would be 0. And then M0800B, worsening in pressure ulcer status since admission stage 3 would now be a 1. So again, to review the rationale for that, the stage 2 pressure ulcer that was present on admission was coded on the admission assessment as 1 because it was based on the initial assessment done when the patient arrived to the LTCH. But on discharge, the stage 3 pressure ulcer, although it was not present upon the patient's admission to the LTCH, was acquired while he was out during a program interruption at the short-term acute hospital. So therefore, M0300C1 should be coded as a 1, M0300C2 should be coded as a 0, and M0800B should be coded as a 1 on a discharge assessment. Program interruptions, the continued rationale is that the patient returns to LTCH within 3 calendar days and would not be considered a new admission. If he had stayed out longer than the 3 calendar days, we would have discharged the patient, and you would have done already a discharge assessment, and therefore he would be a new admission. But in this case, the 3 calendar days, he returned from that short stay acute hospital. Any new pressure ulcer formation, increase in numerical staging that occurred at that acute care hospital, during that program interruption should not be coded as present on admission. So next, I'd like to just review unstageable pressure ulcers. Visualization of the wound bed is necessary for accurate staging. Pressure ulcers that have the eschar or slough tissue present so that you can't really see the anatomic depth of the soft tissue damage. It can't be visualized, it can't be palpated, so they are classified as unstageable. If the wound bed is only partially covered by the eschar or slough, and the extent of the soft tissue damage can be visualized or palpated, the ulcer should be numerically staged and should not be coded as unstageable. Another type of unstageable ulcers are those that are covered by a non-removable dressing or device. Known pressure ulcers that are documented in the record covered by a non-removable dressing or device should be coded as unstageable. Examples would include a primary surgical dressing that can't be removed or an orthopedic device or cast. Known does indicate that it is documented and that there is information in the medical record that says the pressure ulcer exists under that non-removable dressing or device. I'd like to talk a little bit about Kennedy ulcers. These are skin ulcers that occur at the end of life, and they are known as Kennedy or terminal ulcers. It's believed that the etiology is due to poor tissue perfusion issues that happen during the end of life to the organs and resulting skin failure. The evolution and appearance differ from a typical pressure ulcer, and generally they appear 6 weeks, 2 or 3 days before death, and they can present as a pear-shaped purple area with irregular borders. Skin ulcers that occur at the end of life are not captured in Section M of the LTCH data care set. Realize, though, that this should be well documented in the medical record for you to be able to not capture this in Section M of the data set. However, they should be assessed and staged using the pressure ulcer staging system as it is part of the care plan for the patient. Some other coding tips. You'll see terminology referring to healed versus unhealed ulcers, and this refers to whether the ulcer is closed or literally closed or open. Stage 1 pressure ulcers, suspected deep tissue injury, and unstageable pressure ulcers, although closed, would not be considered healed. Just some discussion about mucosal pressure ulcers. They are not staged using the skin pressure ulcer staging system because anatomical tissue comparisons can't be made. So ulcers that are related to nasogastric tubes, oxygen tubing, ET tubes, urinary catheters, and even mucosal ulcers in the oral cavity should not be coded in the LTCH care data set. So I'm going to turn it back over to Jen, and she's going to actually give you some coding guidance for some special populations.
Thank you, Vicki. So the following examples I'm going to provide are coding guidance for patients with developmental disorders, intellectual disabilities, and acquired brain injury. And we know that that represents a large majority of our patients in the LTCH setting. For these example scenarios, there will be no knowledge check pulled, but please follow along with the examples and formulate your thoughts on how you would code the section in the given scenario. We know that in our facilities, not all patients communicate with clear verbal speech, and oftentimes our clinicians need to interpret the want of the patient. In this example, we have a patient with intellectual disabilities and speech disorder who uses simple gestures and speech sounds rather than words to communicate their needs and wants. The patient does not read or write. When the patient is thirsty, they will point to the sink and produce speech sounds. It is clear to the staff who work with the patient that the speech sound communicates that they are thirsty. After providing the patient with water, they do not make any more gestures or speech sounds. How would you code BB0700 expression of ideas and wants? So for BB0700 in this scenario, we would code 2, frequently exhibits difficulty with expressing needs and ideas. The rationale for this is that the patient frequently exhibits difficulty with expression and relies only on gestures and speech sounds to express their needs and wants, which may be only understood by family or caregivers of this individual. While some patient-communicated needs can be met somewhat easily due to staff instruction surrounding the patient's communication patterns, other needs will be more challenging to convey to the staff. Here's another example, and this one relates to BB0800, Understanding Verbal Content. An adult patient with intellectual disability may be able to understand simple or familiar verbal or nonverbal communication by the staff. The family has instructed staff in specific methods of communication for this patient. The CNAs use these methods to communicate with the patient when initiating and facilitating completion of self-care activities. The CNAs have stated that the patient will sometimes follow simplified spoken direction. However, at other times, the patient looks confused and does not complete the task unless further gestures and nonverbal cues are provided to encourage task completion. How would you code BB0800, Understanding Verbal Content? So in this scenario, BB0800 would be coded as 2 sometimes understands, understanding only basic conversations or simple, direct phrases, frequently requiring cues to understand. The reason for this is that our patient sometimes follows spoken directions, but other times will look confused and not complete the task unless other gestures or nonverbal cues are used. This next coding scenario is related to C1610, Signs and Symptoms of Delirium. In this scenario, our patient has Down syndrome and is in our LTAC for the management of a chronic ventilation and respiratory needs. Per the patient's group home caregiver, the patient's intellectual disability baseline is mild to moderate. The patient consistently follows very simple directions related to self-care, and the caregiver provides the staff with detailed directions and communication with this patient. The patient usually has a calm demeanor, is alert and cooperative in her home environment, as well as during prior hospitalizations. However, during the first 2 days of her admission, the CNA and nurses report that the patient is sometimes difficult to arouse and often fluctuates between agitation and a calm demeanor. So how would you code C1610, Signs and Symptoms of Delirium? So there's a couple aspects of section C1610 that we would code in this scenario, and so I'll go through each of those. Acute onset and fluctuation course would be coded as for C1610A would be coded as 1 yes, and C1610B would also be coded as 1 yes. Inattention, section C1610C would be coded as 0 no. Disorganized thinking would be coded as C1610D, 0 no. An altered level of consciousness in section C1610E1 would be coded as 0 no, and C1610E2 would be coded as 1 yes. And I'm going to go through the rationale for that right now. So upon the LTAC admission, the patient's cognitive patterns were compared to the group home caregiver report of the patient's baseline prior to the admission. The patient exhibited an acute onset of fluctuation in their behaviors, the agitation, and altered level of consciousness, the difficulty to arouse. The assessment coding indicates the observed signs and symptoms of delirium during the patient's admission assessment period. And scenario number 4 for coding special populations is related to H0350, bladder incontinence. In this scenario, an adult male patient with an acquired brain injury is usually continent of urine. However, when his family leaves after visiting, the patient routinely is incontinent of urine on the floor. The patient has a behavior plan which addresses his behavior, and the patient's psychologist has been working with him on managing his behaviors after separation from his family. When asked why he has been urinating on the floor, the patient indicates that he is upset because his family has left. Neurologist input may be needed to determine if this issue is behavioral versus due to his acquired brain injury. How would you code 0350 bladder incontinence in this scenario. So we would code this as 0, always continent. And the rationale for this is that in this example, the patient with the ABI is continent with the exception of an intentional voiding on the floor after separation from his family. This has been diagnosed as a behavioral issue, so this void would not be considered an episode of incontinence. If a patient with behavioral issues purposely voids on the floor, this voiding would not be considered an episode of incontinence. And now we'll move on to Section O, influenza vaccination season. The definition of the influenza vaccination season is different from influenza season. Information about current influenza season can be obtained by accessing the CDC seasonal influenza website found at the cdc.gov/flu site. CMS has clarified that flu vaccination data is collected year-round, so providers should report flu vaccine data, especially for patients who are in an LTCH during the influenza vaccination season. Specifically, any patient who is in a facility 1 or more days from October 1st, or when the vaccine becomes available, and March 31st should have this information documented regardless of the time of year. Influenza season begins July 1st and ends July 30th, but influenza vaccination season begins October 1st and ends March 1st. If the patient was in the facility during the influenza vaccination season, again that's October 1st to March 31st, and was assessed and received the vaccination, the information is reported on the LTCH Care Dataset tool. Remember, the influenza season is not the same as the influenza vaccination season. The information is reported regardless of whether the patient's admission or discharge occurred inside or outside of the vaccination season. We'll go through some examples that will help to clarify this concept a little bit later in the slides. Regardless of the influenza vaccination season date range, the LTCH should document vaccination year-round. However, for the quality measure, only the records of patients who were in the facility 1 or more days during the influenza vaccination season are used in the calculation. To summarize, you must report their vaccination, but they are not included in the calculation. Here is a visual representation of Section O on the LTCH Care Dataset, which includes whether or not the patient received the vaccination in the facility for the current influenza vaccination season, as well as the date of the receipt and the reasons why a patient would not have received the vaccination if that were the case. Going through Section O more specifically, Section O0250A asks, did the patient receive the influenza vaccine in this facility for this year's influenza vaccination season? You would code this section 0, no, if the patient did not receive the influenza vaccine in the LTCH, and you would proceed to O0250C, and you would state the reason. Or you would code 1, yes, for vaccines given to the patient in the facility 1 or more days during the influenza vaccination season, and then continue to O0250B. Section O0250B is the date of the vaccination receipt. Two important coding tips for this section include entering the date that the patient in your LTCH received the vaccine. You should not leave any boxes blank. And if the date is unknown or the information is not available, a single dash needs to be entered into the box. Some of the reasons that a patient would not have been vaccinated are listed in Section O0250C. They include 1, patient not in the facility during this year's influenza vaccination season. 2, received outside of this facility. 3, not eligible, medical contraindication. 4, offered and declined. 5, not offered. 6, an inability to obtain influenza vaccine due to a declared shortage. Or 9, if none of those apply, you would use number 9, none of the above. The annual supply of influenza vaccination and the timing of its distribution cannot be guaranteed in any year. Therefore, if a declared shortage is made, you can utilize code 6 to reflect a shortage as a reason that the patient would not have received the vaccination. This does happen from time to time based on supply and demand. So let's look at some examples that help us through the influenza documentation. There are no knowledge checks or polling questions associated with these scenarios either, so please follow along and see if you can determine how to code section O. Here we have a patient who was admitted on October 8th and received the vaccination on October 10th in the LTCH. The patient was discharged on November 1st. Their entire stay was during the influenza vaccination season. Would this patient be reported on the LTCH care data set? In this scenario, the answer is yes. The patient was in the facility 1 or more days during the influenza vaccination season and was assessed and, where appropriate, received the influenza vaccination for the current influenza season. This information would be reported on the LTCH care data set regardless of whether the patient was admitted or discharged during or outside the influenza vaccination season. And so just to review, the coding would be as follows. O0250A would be 1 yes. O0250B would be coded as 10-10-2016. And O0250C would be skipped. Let's try another one. Here we have a patient who is admitted to the facility on March 31st, which is the last day of the influenza vaccination season. The patient was vaccinated on April 5th in the LTCH and discharged on April 15th. Would this patient be reported on the LTCH care tool? In this example, the patient was vaccinated for the current influenza vaccination season. The vaccination item should be completed even though the patient was discharged after the influenza vaccination season, and the patient was in the LTCH for 1 or more days during the influenza vaccination season. Therefore, our coding would be for O0250A, 1 yes. O0250B would be coded as 0405-2016. And O0250C would be skipped. In this example, the patient was vaccinated on September 3rd prior to their admission to the LTCH on September 15th. The PCP was the one who provided documentation to the LTCH of the patient's vaccination. They were discharged from the LTCH on October 1st, the first day of the vaccination season. How would you code section O? So in this scenario, we would code O0250A as 0, no, not vaccinated in the facility. You remember the patient was vaccinated at the PCP. We would code O0250B as a skip, that one would be skipped. And O0250C would be coded to received outside of this facility. And finally, in this example, a patient who was admitted prior to the influenza vaccination season, patient having been vaccinated by the LTCH during the influenza vaccination season on October 15th, and the patient was in the LTCH for 1 or more days during the influenza vaccination season. So in this case, how would you code section O? So in this scenario, you would code O0250A as 1 yes. You would code O0250B as 10-15-2016. And O0250C would be skipped. So now let's check your knowledge on Section O using the polling feature. In this scenario, Mrs. V was admitted to the LTAC on April 1st, 2017. It is the LTAC's policy to vaccinate patients through the end of May. So Mrs. V is vaccinated in the LTAC on April 14th, 2017 and discharged April 15th, 2017. How would you code O0250A? Did the patient receive the influenza vaccine in this facility for this year's influenza vaccination season? You would code 0 no or 1 yes. And I see that many of you have submitted your responses, and the majority of you answered 1 yes, and that is correct. So here's our rationale. For this section, 0250B, we would code this, we're going to go through the rationale in 1 minute. One more question first. So here, in addition, same scenario where Mrs. V was admitted to the LTAC on April 1st, 2017, vaccinated on April 14th, and then discharged on April 15th. How would you code O0250B, the date that the vaccine was received? A is 04/01/2017, B is 04/14/2017, or C is 04/15/2017. And I can see 100% of you got that one right. That's an easy one. So now our coding to summarize Section O would be for O0250A would be 1 yes, and then as mentioned, O0250B would be 4/14/2017, and we would skip O0250C. The reason for this is that Mrs. V was vaccinated for the current influenza season. The vaccination items should be completed even though she was not in the LTAC for 1 or more days during the season. Patients should be offered the vaccine after the influenza vaccination season if consistent with facility policy. So if your policy extends beyond the influenza vaccination season, you would continue to vaccinate patients in accordance with your policy. In this scenario, Mrs. V would not be included in the quality measure, however, as her stay was outside of the influenza vaccination season. Now I'd like to turn the floor back over to Tree Lee for some LTCH QRP data analysis.
Great, thank you very much, Jen. Now we will review some findings from our data analysis and some reminders as a result from looking at the data. We would like to thank everyone for all the effort in collecting accurate data. We have examined the data, and much of the data patterns we observed are patterns we expected. One area we looked at was functional performance for LTAC patients. One of the quality measures data shows that LTAC patients who underwent invasive mechanical ventilation are gaining function in the area of mobility as expected. Data also shows that few LTAC patients have new or worsened pressure ulcers during the LTAC stay. Lastly, our data shows that LTACs are completing the influenza vaccination items year-round as required by the LTCH QRP. Next, we'll go over some coding reminders based on our data analysis. For section GG, coding an item as 07, patient refused, would indicate that the patient did not perform the activity and a helper did not perform the activity for the patient during the 3-day assessment period. In other words, this means that the activity did not occur at all during those 3 days. A therapist would not code 07, patient refused, because the patient was not assessed performing the activity. For example, a therapist or nurse is responsible for coding the oral hygiene item, and the therapist or nurse did not assess the activity in therapy during the last 3 days of the patient's stay. For coding, the therapist should interview the patient, nurses, direct caregivers, nursing assistant, or other care staff to determine the patient's level of independence with the activity and code 01 through 06 as appropriate. We did find in our data that patients were admitted to the LTAC with a code of 02 substantial maximal assistance through 06 independent for oral hygiene, but then discharged with a code of 07 patient refused. We encourage clinical staff to gather information from others in order to accurately assess patients. For section GG, coding an item as 09, not applicable, indicates that the patient did not perform the activity and a helper did not perform the activity for the patient. And the patient or a helper did not perform the activity prior to the current illness, injury, or exacerbation. We would like to note that this is prior to the current episode of care, such as before the day of admission to the acute care, not prior to LTAC admission. For example, a patient received all nutrition and liquids through tube feedings prior to the onset of his new medical condition. The patient did not eat or drink anything by mouth. The patient was admitted to the LTAC receiving nutrition and liquids through tube feedings and does not eat or drink by mouth. For coding GG0130A, eating should be coded as 09, not applicable for the admission assessment. The key information here is that the patient received all nutrition and liquids through tube feedings prior to the onset of his new medical condition, which is likely prior to the day of admission to the acute care hospital. Previously, Vicki very thoroughly went over the skin assessment items. From the data we've seen for Section M, we would like to reinforce the coding of the skin assessment items at the time of discharge. If a pressure ulcer is observed at discharge, determine whether the pressure ulcer was observed at the time of admission. For example, a stage 3 pressure ulcer was observed at discharge. This same pressure ulcer at discharge was at stage 3 upon admission. Therefore, a pressure ulcer would count as a stage 3 pressure ulcer that was present upon admission on the discharge assessment. This means that the pressure ulcer was not new or worsened from the time of admission to discharge. Another example, a stage 3 pressure ulcer was observed at discharge, and this same pressure ulcer was a stage 2 upon admission. Therefore, a pressure ulcer worsened since admission, and it would not be coded as present on admission at discharge, since it was not stage 3 upon admission. For the influenza vaccination items, we would like to remind everyone that the influenza vaccination season starts on October 1st and ends on March 31st of the following year. Communities may extend an influenza vaccination season. However, the items are based on the October 1st through March 31st season. For item 00250C, if influenza vaccine not received, state reason, code 1, patient was not in this facility during this year's influenza vaccination season, can only be used if the patient was not in the LTAC 1 or more days during the influenza vaccination season. For example, the patient was admitted to the LTAC on June 16, 2017, and discharged on June 30, 2017, and the patient did not receive the influenza vaccine, then the patient can be coded as 1 for item 00250C, stating that the patient was not in this facility during this year's influenza vaccination season. Now I'll pass it on to Mark so he can introduce the question and answer section.
Thank you, Tree, and thank you to everyone for sharing the findings related to the data and the quality measures submitted by long-term care hospitals. I'd like to welcome Lorraine Wickheiser from CMS, who's going to answer some of the questions that were submitted during today's call. Lorraine is a nurse consultant at CMS. Currently, she directs coordination for the LTCH QRP within the Division of Chronic and Post-Acute Care, or DCPAC. She oversees several contractors to coordinate efforts in measure development, data collection, analysis, public reporting, and trainings related to quality improvement and quality reporting initiatives, which included the launching of the LTCH Compare website. She has extensive clinical and training experience. Mrs. Wickheiser has contributed to the Long-Term Care Hospital Quality Reporting Program Manual, Provider Threshold Reports, and most recently, the Provider Review and Correct Reports. Lorraine. I'd like to welcome everyone.
Yeah, thank you.
The first question is related to LTCH QRP provider resources, and the question is, where can I locate additional training, videos, and materials?
And before I provide that answer, I just want to let everyone know, as a reminder, that on the CMS Quality Reporting Help Desk questions, that they're not secured and they are not to receive protected health information or patient-level data with direct identifiers. Submitting any kind of patient-level data or protected health information may be a violation of your facility's policies and procedures, as well as a violation of federal regulation or HIPAA. Do not submit patient identifiable information, for example, date of birth, Social Security number, health insurance claim number, to any of these addresses. If you are unsure of whether the information that you are submitting is identifiable, please contact your institution's privacy officer. So to answer the first question submitted, where can I locate additional training videos and materials? The training materials, including the links to any of these materials and the recordings and videos associated with these training sessions, as well as the notices about upcoming trainings, are available on the LTCH QRP training webpage. And that's located at www.cms.gov, Medicare Quality Initiatives. Mark?
Thank you. Yes, I was just hearing some static. We'll be able to clear that up, hopefully. The next question is related to Section GG. What is the impact for a patient who does not meet their discharge goal? Some patients experience medical decline where they cannot complete some or all of their discharge goals.
At this time, compliance determinations are based on whether or not an LTCH reports the required LTCH care dataset quality items, also including the CDC measures, as opposed to the LTCH's performance on these quality measures. So there's no additional penalties for not meeting the goals on the LTCH QRP. The discharge goal code may be higher than, equal to, or less than the admission assessment code, depending on the patient's status and prognosis. Code 01 through 06 may be used to code these discharge goals, but do not use the code 07, 09, or 88 to code discharge goals.
Next question is also from GG and appears related. Would you please clarify the following? In Section GG of the LTCH Care dataset, we are only required to enter one goal. Providing we have entered at least one goal in Section GG, how would we code items that do not have a goal?
Okay. We encourage LTCHs to set goals for any of the activities that are part of the patient's care plan or plan of care. So to know, completion of at least one discharge goal is required from one of the self-care or mobility items to fulfill the requirements of the LTCH QRP. So in other words, one self-care or one mobility item must have a discharge goal. This is part of the requirements for the quality measures, included application of the percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that addresses function, and also for the measure of percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that addresses function. So failure to submit at least one discharge goal for one of these self-care or mobility items may result in a 2 percentage point reduction of the LTCH's annual payment update. Also, the discharge goal code may be higher, as I've already stated, equal to or less than the admission assessment code, depending on the patient's status and prognosis. Remember that you can code 01 through 06, but you do not want to code 07, 09, or 88 for the discharge goals. If a goal is not entered for a self-care or mobility item, code a dash. As previously stated, the LTCH QRP requirements a minimum of one self-care or mobility goal discharge.
Thank you. The next question is related to Section J. It's a two-parter. How is J1900, number of falls since admission, coded if a fall occurs in the home or community after a patient has been discharged from the LTAC?
Okay, and I think we talked on this on the slides, but if a patient goes home, the LTAC would typically submit a discharge assessment, and then if the patient returns, they would submit a new admission assessment, as the patient did not experience a program interruption because it wasn't a transfer to another hospital or facility or medical services.
Thank you. And the next part is, what then is the time frame for reporting a fall that happens at home?
Well, normally no data from the interval at home between the discharge and admission assessments would be reported on either assessment.
Thank you. The next is Section M. If a patient comes in with an unstageable pressure ulcer due to eschar, which was surgically debrided, after debridement, the pressure ulcer became a stage 3 pressure ulcer. It was coded in MO300F at admission prior to debridement, but would this then be a worsening stage 3 pressure ulcer, and should this be coded as stage 3, not present on admission at discharge?
It's a little involved, but if an unstageable pressure ulcer is observed during the admission assessment and then during the patient's stay, is debrided, and then subsequently able to be numerically staged, the pressure ulcer is to be considered not worsened and present on admission when completing the patient's discharge assessment. If, subsequent to this numerical staging, the pressure ulcer further deteriorates and then is restaged at a higher numerical stage 2. Sorry, stage 2, the pressure ulcer would be considered worsened and then not present on admission. In this scenario that we're talking about, if there were no other pressure ulcers present on admission, then the admission assessment coding should be as follows. So for the MO210, would be unhealed pressure ulcer would equal 1, yes. MO300F1, the number of unstageable pressure ulcers due to coverage of wound bed or slough and or eschar would equal 1. If there were no other pressure ulcers, you could code 0 for all other admission assessment items. If the ulcer under debridement was first staged as a numerical stage 3 ulcer and then did not worsen by discharge and there were no other pressure ulcers noticed, discharge assessment coding should be as follows. MO 210, unhealed pressure ulcers would equal 1, yes. MO 300C1 would be the current number of stage 3 pressure ulcers would equal 1. MO 300C2, number of these stage 3 pressure ulcers that were present upon admission would equal 1. If there were no other pressure ulcers at discharge, code all other items including the MO 800A through F, which are the worsening in pressure ulcer status since admission, as 0.
Thank you. That was very involved, as is the next question from Section M. It's equally detailed, and I should pause to say that we will provide these questions and answers as part of the materials from today's proceedings. This next question that's also related to pressure ulcer is, we had a patient admitted with a pressure wound that was classified as unstageable due to DTI and evolution. Parenthetically, it says present on admission. Over the course of the patient's stay, the wound became stageable at stage 2. It remained stage 2 until discharge. What is the correct way to report this on the LTCH care dataset? Our understanding is that it is not considered a worsening pressure ulcer. Would we list this as unstageable wound that remained at discharge? Do we list it as unstageable on admission and stage 2 at discharge MO 300B1, but document that it was present on submission MO 300B2, and they conclude, thank you for your assistance?
Thank you, Mark. Again, it is somewhat involved, so we'll go through the steps as the questions were asked. On admission, your coding would be, we would start with MO 210, unhealed pressure ulcers equal 1, and that would be yes. MO 300G1, the current number of unhealed pressure ulcers that are unstageable due to deep tissue injury equal 1. Then the remaining pressure ulcers would be coded 0 if no other pressure ulcers were observed. If a pressure ulcer was unstageable on admission and is unable to be numerically staged during the stay, and that stage doesn't worsen by discharge, then you could code the appropriate stage in MO 300. But do not code this ulcer as worsened on the discharge assessment. The pressure ulcer you describe is staged as a stage 2 pressure ulcer and does not heal by discharge. So it would be considered as an unhealed stage 2 pressure ulcer at discharge. If there were no other pressure ulcers, your discharge assessment coding would be MO 210, unhealed pressure ulcers 1, yes. MO 300B1, the current number of unhealed stage 2 pressure ulcers equals 1. MO 300B2, the number of these stage 2 pressure ulcers that were present on admission would equal 1. And then your MO 800, worsening in pressure ulcer status since admission, would equal 0.
Thank you, Lorraine. We have finished responding to all the questions that we're prepared to answer today. Some of the questions submitted will require additional research. I want to assure everyone that answers to all questions submitted during today's webinar will be posted to the CMS website, along with the post-training materials and a link to video recording of today's presentations in the near future. That goes for questions through the online submission form as well as the Q&A. We thank everyone for joining today's webinar and hope you have a wonderful afternoon.